So, good evening, everyone.
Good evening, ma'am.
Good evening, ma'am.
So, today is our first session from the Gujarat ANEI. Myself, Sarmista, I am DGM Nursing and I'm handling the ANEI from the Gujarat. Today, we are going to present the case study of early recognition, timely escalation, and recovery in the replaced ALL transplant patient. If we can discuss what is the ALA. So ALA is the acute lymphocytic leukemia that also called as a acute lymphoblastic leukemia is a fast growing cancer of the blood and bone marrow. If you can see in the globally data, so ALA accounts for 12% of all leukemia cases. It is the most common cancer in children. Annual incidence, if you can see children 0 to 14 years, is 3 to 4 case per lakh, and in adult is 1 to 2 case per lakh. Global burden, if you can see, organization like the World Health Organization, 65 to 70,000 new cases per year worldwide. We can see the survival rate. So prognosis depend in the age and the genetic and the treatment access. In the children is a 5-year survival rate. It's 85 to 90%. And in adult 5-year survival rate is 35 to 50%. And if you can see the mortality, so globally 40,000 deaths per year, and mortality rate are higher in low and middle income countries, and patient diagnosis at later stage. So this is the some statistic data which I have shared with you. I'll request to Poonam, I request to Miss Dharini Thakkar, who is the case manager working is SCG Asta Cancer Center, and then the few leadership insight from the Poonam Talreja. He is the chief nursing head in the SCG Cancer Center, and will summarize with the Miss Vidhi Vipul Patel, is a student from the JG College of Nurses. So I request you team, please start to focus on this case study.
Namaste all. To begin with, ma'am, my audio is clear?
Ma'am, it is a echo sound. I think.
Okay. Am I audible now?
Yes, ma'am.
Yes.
Yeah, okay. To begin with, I'll start with thanking to Miss Sarmista ma'am and Miss Poonam ma'am for believing in me and giving me this opportunity. Uh, Today I'm going to present a case on ALL, which is a relapsed case. With further more delay, I would like to share my screen. Someone just help me and tell me, confirm that is my screen is visible or not. Is it visible?
Yes. Please do in the PPT,
Yes.
do the double click.
Okay. So
Yeah.
let us begin our today's case of acute lymphoblastic leukemia. Acute lymphoblastic leukemia is basically a blood cancer. Before jumping into the case study itself, let us discuss about the disease condition first. So, as mentioned in the PPT, it is a rapidly progressing malignancy of the bone marrow. Bone marrow is a spongy tissue in our bones, especially the long bones. The cancer is characterized by overproduction of the immature lymphoblast. As you can see in the picture, the lymphoblast, which is unmatured cells of blood, have crowded out the normal blood cells. So, acute lymphoblastic leukemia stands for the condition where progressing malignancy of bone marrow, which is characterized by overproduction of the immature lymphoblast cells. It is commonly seen in children, but it also affects adults. Speaking of disease markers, we have four parameters. As it is a blood cancer, the cells of blood, red blood cells, white blood cells, platelets, which are growing fast, and the maturity is also compromised. So those cells are compromised anatomically as well as pathophysiologically. So it won't function well. The parameters, if we discuss, hemoglobin, it will go down and predisposes anemia. Platelet, it will go down and thrombocytopenia will occur. WBC count depends on the current condition of the patient. It may rise, it may go down. If patient catch any infection, as we know that immune cells are not there, so our army is not there and patient has got any infection, so WBC count will increase. Peripheral smear circulating lymphoblast will be increased, as we can see in the picture put in the slide. So let us go towards our case. Here we have 20 years male patient. As I have mentioned in the introductory part, it can affect adults as well. Diagnosis was relapsed acute lymphoblastic leukemia. So we discussed ALL. Now what is this relapsed? So relapse is basically when ALL is diagnosed, patient will be treated with any chemotherapy regimen. Now these chemotherapy drugs supposed to kill all those lymphoblasts which are immature and leukemic. But few of them managed to survive. And those kept growing inside the patient's bone and occur relapse. So remission period will be lowered and relapsed acute lymphoblastic leukemia will occur. In this particular patient, reason for admission was relapsed acute ALL, in which doctors and family have decided to go with allogenic hematopoietic stem cell transplantation. In normal words, if we say, the family has chosen BMT therapy to treat their child. Patient was admitted on 29th of January 2026, and with the longer period of admission, he was with us till 33 days and got discharged on 2nd of March 2026. If we see about the symptoms, so basically disease symptoms are anemia, frequent infections, bleeding and bruising, petecia, bone pain, joint pain, enlarged lymph nodes, swollen liver or spleen, neurological symptoms if CNS is involved, and loss of appetite, weight loss, and night sweats. All the symptoms are suggestive of what we have previously discussed regarding functions of blood cell. As red blood cells are low, anemia will be there. As WBC are compromised, infection will be frequently there. As thrombocytopenia is there, so patient will bleed easily. In our patient, the present symptom was anemia, frequent infections, petecia was seen over overall the body, bone pain was there, enlargement of lymph nodes, all neck, armpit, and groin was there. Patient had lost his appetite. Weight loss were remarkably seen, and night sweats were also reported. Let us deep dive into the case with the clinical history. So, these are the presenting symptom of the patient, and in initial stage in December 2025, patient was diagnosed with ALL. As I've mentioned earlier, he was treated with the hyper CVAD-B chemotherapy protocol. This particular protocol involves two drugs, methotrexate and cytarabine, which are basically given to eradicate the residual leukemic cells, and it prevents CNS involvement as well. And remission will be longer as it prevents relapse. Unfortunately, in the post-treatment evaluation, patient's minimal residual disease was assessed. Now, what is MRD? As we have seen in the we have discussed in the relapse terminology, the left out lymphoblast after giving chemotherapy are counted with using different methods and to diagnose MRD. So minimal residual disease was performed and the finding was 0.012%, which was higher than the threshold. The normal range is less than 0.01%. Imagine the condition of this patient. And it was found positive. As it was found positive, patient undergone salvage chemotherapy. Nelarabine, cytophosphamide, and etoposide again given to kill those lymphoblasts, but they still managed to survive. As we can see in the follow-up investigation, flow cytometry test was done to check the persistency of MRD. Initially, when it was found positive, the level was 0.012%. After salvage chemotherapy, it was still raised to 0.0, 14%. So here we can see that patient has developed persistent MRD positivity. To support this diagnosis, the hematological findings were also confirmed, which predisposed at hemoglobin 11.3 gram percentage, and WBCs were severely pancytopenic state, 2510 cells per microliter. So clinically, patient was deteriorated and predisposed to the high risk of bleeding and infection. And diagnosis was confirmed as relapsed ALL and persistent MRD positivity. So here comes the tougher time for the family as well as for the patient, where they have to decide that two chemotherapy regimens have failed and now what to do. So after a long pause and psychological support, our family decided that the patient will go under allogenic hematopoietic stem cell transplantation. From here, nursing team's challenge begin, as we all have seen that patient is pancytopenic and neutropenic as well. So what actions our nurses did and how they have managed, that we'll see in the further slides. Let us discuss about sequence of events. Once the patient was admitted in BMT, bone marrow transplant is a tougher for patient as well as the family. So, to manage the patient clinically, the first step was patient was central line accessed and immediately put under neutropenic precautions. During phase 1, total body eradication administered twice daily. Speaking of TBI, it is a therapy given to kill all the residual cells which are present in patient's blood. So it was given twice daily to the patient. At phase 1, nursing care focusing on fatigue management, skin core of the patient, and psychological support for the patient as patient is adapting to the new environment, admitted for the longer period in BMT. Only one family member we have allowed. Our IPR will be in the introductory phase. So patient needs psychological support here. Moving forward to stage 2, where conditioning regimen was given. Now, conditioning regimen is something that after total body eradication, uh, whatever cancerous cells are present, conditioning regimen is a chemotherapeutic drug which will be decided on particular patient basis. It was administered, drug injection fludarabine was given 25 mg per meter square. Here, at this point, nursing care focused on strict monitoring, vital signs, fluid balancing, and early signs of infection and toxicity as our patient is still neutropenic. Now, the third stage on 5th of February 2026, harvesting was done. As it is allogenic, patient's father have donated, and the nursing care here not only focus on the patient, we have cared for the father as well, ensured his safety and aseptic coordination during harvesting process. Here, the multidisciplinary team approach has a remarkable impact. Nurses, the harvesting team, and our bone marrow BMT therapy team all were involved very nicely, and they were in good coordination. From now, after harvesting, it was being infused in the patient using central line. So day 0 is the counted as infusion day. In nursing care, it focused on continued monitoring of vital instability and immediate infusion reaction. It is similar to that of blood transfusion, but more and more serious than that. And critically, it has to be critically monitored and strictly documented. Going further, it is day +3, 8th of February 2026. Patient has developed CRS, which is cytokinin release syndrome. This particular disease or this particular complication suggests that our patient's body is reacting to the cells which were transfused. The condition showed up as fever of 100 degree Fahrenheit, hypotension 92 per 54 mm of Hg, diarrhea 5 episodes in a day. So speaking of management perspective, it was initially tried to be managed with IV fluids and vasopressin support, but our patient not recovered with this. So doctors have decided to escalate the antibiotic, and empirical antimicrobial drug injection tocilizumab 400 mg was administered. With this drug's effect, the therapeutic effect was in our favor and patient was recovered. Now, apart from cytokinase release syndrome, other few complications were also seen and which was managed by our nursing team very nicely. The complications were febrile neutropenia, septic shock, mucositis of third grade, and diarrhea. So let us see how our nurses rescued this patient. Speaking of mucositis, the oral care was given. Mucositis is inflammation of the mucous membrane. In this, oral care was strictly given. CAG mouthwash was used and patient was kept nil by mouth. Let us come to septic shock. As we have seen, empirical antibiotics were administered, vasopressor support, IV fluids, and strict monitoring and documentation was ensured. Febrile neutropenia, hourly body temperature monitoring was done by our nurses, strict asepsis and adherence to bundle care. Here, our nurses showed a very good escalation with the escalating the body temperature raises and manage the patient very well, as this patient was accessed with central line at the point of neutropenia where patient develops high body temperature. uh, Role of infection control comes here with CLAPC. It was suspected and culture was sent, but it was in our favor. The culture was negative. This shown that our nurses have done very good central line care and aseptic techniques were maintained very nicely. Now, as we have seen that we have managed our 4 complications very nicely on day plus 24, that is 1st of March 2026, is a green flag for our nurses, patient, and as well as the family, as neutrophil engraftment was achieved. Engraftment typically means that what transfusion we have given to the patient's patient's body receptors have accepted it and engraftment was achieved. Count was increasing. Platelet engraftment was also achieved and patient was clinically declared stable. On day 25th, he was discharged with good hemodynamical condition. So here we have seen that how our nurses have managed this case very well. Thank you. This is end of my part. Now I will hand over to Miss Poonam ma'am. She will discuss about the managerial perspective in this case. So Poonam ma'am.
Good evening, all. Am I audible?
Yes, ma'am.
First of all, I would like to thank Annie and Sarmishta ma'am for giving me this opportunity. And nice presentation, Dharini. You had given so many information regarding the patient and patient outcome. So, as per my managerial perspective, as per this case, is like that if we are treating patient in bone marrow transplant unit or in the stem cell transplant unit, it is the same. So as a manager, we have to look after the leadership and governance. In that, we should dedicated manager or dedicated in charge should be there in stem cell care unit. And as per the manpower and skill mix, so as per the guideline, the nurse patient ratio is 1:1. But in some hospital, it may be changed as per the hospital protocol, that in stable patient they are giving the 1:2. But as per the ideal protocol, we have to give the 1:1 in the bone marrow transplant unit. And in that, the mix of trained and senior nurse should be there. The competency level is 4 or 3 levels should be there. As per the point of the quality and safety, then strict adherence to the protective isolation and asepsis, central line and PICC care, high alert and chemotherapy medication safety. Because in that patient, you had given the conditioning chemotherapy. In conditioning chemotherapy, what happened? All the healthy cell may die. So the patient counts will come at 0. So it is very crucial period at the time of conditioning. So at that time, the monitoring for the critical situation and monitoring for the vitals are very critical in that scenario. Training and education, as we all know, training is a continued process. So in particularly in the BMT unit, structure BMT induction and structure annual competency validation should be there. And in service education, skill drills, fellowship, specialty program should be cultivated for the safety and for the competent nursing. For staff privileging for the BMT nurse, so after the induction, structure induction and the preceptorship and in-service education, the privileges should be there. And register nurse, active council registration, 1 to 2 years of oncology experience can be trained for the stem cell transplant, because the basic oncology practices are aware for him or her. May I request to please silent your audio? So after oncology awareness, we should give the specialized training to them. And after completion of the BMT induction and infection control training, privilege should be there as per the level, that level 1, level 2, and level 3. It is applicable to all the nursing staff, but in the BMT unit, we have to strictly adherence to the privilege, because we are working with the very critical patients. So level 1 is a supervised, so basic BMT care, isolation and documentation should be given. Level 2 is a independent care, nurse can given that central line care, transfusion therapy, chemotherapy. And level 3 is advanced competency. In that, we have given the privilege of immediate post marrow transplant care, emergency during the transplant, post transplant emergency management, and mentoring or train the junior ones or the level 1 or level 2 staff. As per Dharini's talk, there is a very good escalation was there. So I brief on that, that we should identify the risk on time, and after that we can communicate, or we can escalate to the higher team or the right team. So stem cell transplant care is involving nursing almost, because the maximum time spent with the patients are the nurses. So escalation triggered due to the persistent MRD positivity, because after ALL diagnosed, patient had taken a chemotherapy, and after that patient had gone for the investigation, and that minimal residual disease positivity occurs. So diagnosis happen at that time, but it should be prevent from the previous one also, because after completion of the previous chemotherapy on periodic basis, this specialized test should be done. Severe pancytopenia. What is pancytopenia? In pancytopenia, hemoglobin level is decreased, WBC may increase, and platelet may decrease. So, if all three parameters occurs, then patient is in called neutropenia, and we have to look after the so many risk factors in that. Like if hemoglobin is low, then patient had anemia, and patient felt fatigue, weakness. If the WBC count is high, then there is a more chances of sepsis is there. Septic shock is also occur with the patient. And if the platelets are reduced, then the bleeding and rapid deterioration may occur. So there is a plan for allogenic hematopoietic stem cell transplant requiring the multidisciplinary coordination. In that, alone nurse can't help the patient. But if we are approaching a multidisciplinary team approach, if we are including from the hemato-oncologist then consultant, then medical officer, pharmacy team, nursing team, nutritionist, then psychologist. All are important and all are given have a very crucial role for the outcome of the patient. This factor classify the patient as a high acuity and high risk because it is a relapsed acute lymphocytic leukemia. So the already the complexity is high. Patient admitted with the pancytopenia stage. So there is a chances of bleeding, septic shock, and so as per the patient condition, it is a very high risk patient. So we need a high acuity that we need to give a level 3 or level 2 competent staff to them. For our whom is joining in this webinar, like for staff nurse and student nurse, it is more important that what should we inform and why should we inform. So, as per the staff nurse level, or as per the senior student nurse, you will be become a staff nurse in very few time, in very short period. So, what should be reported on time? Because reporting, escalation, communication is very important. Uh, because if it is a delay, there may be a patient criticality may high, or patient mortality will be high in that case. So we should know the critical CBC value, the normal hemoglobin value, normal WBC value, normal platelet value. As a nurse, we should know, and if any deviation is there, if it is a high or it is a low, then we should escalate as soon as possible to the ward in charge, because ward in charge is available all the time. From morning to evening, in charge should be there. So it should be escalated her or him on a very priority stage. If patient has fever, if patient, we should observe for the bleeding, or bleeding in sense the is there any hematuria is there, or is there a melena is present or no, is patient skin is normal, or any petechia is there, any bruises are there. So it should be escalate, or it should be communicate on a very priority space. Is there any signs of infection is there? Fever is one sign, but patient has mucositis is there. Is there any, and we should assess the skin folding area, like groin area, axillary area. Is there any infection showing? Ensure neutropenic precaution. So in this case, we are using the reverse barrier nursing care. In that, the proper PPE should be there, strict aseptic precautions should be other ones, strict hand hygiene protocols should be followed, bleeding precautions. So we are not giving any intramuscular injection to the ALL patients, and all SARP should be away from the patient care area. And this is this communication should be done with the patient as well as from the relative also. Strict intake output and vital monitoring should be there. As Dharini mentioned, that patient had a 5 episode of diarrhea. So we have to maintain the IV fluid. We have to see the texture of the skin, the tone of the skin, and what patient, because of the mucositis also, patient can't take orally too much. So we have to motivate patient to take as can as possible, or we can give the IV infusion or the IV TPN for balancing the nutrition in the patient. Strict vitals monitoring is there, because one minor change, if we communicate on time, then we can prevent the complication to the patient. So escalation is very important. So staff nurse is playing a very crucial role for managing the patient in very in a good manner. So escalation to treating resident or fellow without delay. This is the key take away, that we should escalate, we should speak up. As a nurse, it is observed that the staff nurses are afraid to communicate with ward nurse, to communicate with the consultant. But remember one thing, if we are communicate on time, if we are escalated the possible complication on time, then patient mortality can be prevented by the nurse. So my dear nurses, please voice up, please speak up. Escalation level 2, if we are watching, because ward in charge or the team lead or the manager of the BMT unit are more experienced, and they can identify risk in very early stage. So communicate MRD, minimal residual disease status, pancytopenia trained should be there, because yesterday what is the patient report, yesterday what is the patient HB, WBC and platelet, it should be trained that it is a decreased or improving patients. So as a nurse, the trend should be analyzed on day-to-day basis, on every result should be analyzed, and it should be escalated to the consultant also. Early involvement of the hemato-oncologist, then transplant physician, then the red flag should be there. He or she is given the red flag to the blood storage or the blood bank for the readiness of the blood product on time and the infection surveillance. She or he should be more cautious that my BMT unit, my stem cell unit is free from microorganisms. So she should take care for the HEPA filter validation, for the positive pressure, and the health of the staff. She should evaluate the health fitness, the fitness of the staff, that patient who is taking, staff nurse who is taking care of the patient is free from any disease or is free from any infection is there. As I mentioned earlier, the patient outcome is not a single person task, is a multidisciplinary team. So we, as a nurse, we are the one who is coordinated with the all the level, from, as I mentioned, from the hemato-oncologist, consultant, medical officer, pharmacy, blood storage, clinical psychologist, physiotherapist, infection control team, critical care team, that all the coordination is done by our nurses. So purpose, why multidisciplinary escalation is there, because if we are red flag or we are alert the blood bank that please ready blood product for that patient, if we are alarming the pharmacy team, we need this antimicrobial products or antibiotics for this patient in advance. So the material management, manpower management and resource management is easy for us, and patient get treatment on time without any delay. So the purpose is why multidisciplinary team is needed, for ensure the readiness for rapid deterioration, optimize the transplant preparedness, and prevent avoidable complications. The another method or the another strategy for the communication, as we, for the internal communication, as we all know that we are using the ISBAR, identification, situation, background, assessment and recommendation. But ISBAR is not limited to the nurse. ISBAR is really applicable to all the multidisciplinary team, like medical officer, pharmacy, clinical psychologist, blood bank, critical care team. So ISBAR is applicable for all, and it should be utilized by all team members. For interdepartment communication, so proper coordination and collaboration is needed, and clear explanation with the patient and with the family. As I mentioned earlier also, patients and family should aware what is the disease status, which are the risk factor for that patient, what is the plan, what are the complication may occur in that case, and reinforcement and take the help or involve the patient and patient relative for the infection prevention. Give education, because we have to give education for the prevention of fall, for the prevention of this arc injury, for prevention of the infection in that patient, and bleeding precaution. If patient fall, then the complications may increase, and the may mortality will increase, because patient had a low platelet count, so there may be a chances of severe bleeding in that case. So we have to involve patient and family for the care and treatment. These are the red flags which are noticed by the nursing team. First is the persistent fever in neutropenic phase. So first of all, the CBC level, then the fever is there or not. We should monitor vitals on a periodic basis. So the BP, the heart rate, respiration rate, and as I mentioned, intake output chart. So we have to monitor the diarrhea, or the how many times patient passed the stool, the how is the consistency is there, what is the color of stool and urine, if patient has vomited or not, is there any bleeding from the coughing or the urine or the stool. We should monitor that. Severe oral pain and inability to tolerate oral intake, because patient had, because of the high dose of chemotherapy, patient developed a mucositis grade 3. So patient had a severe pain and maybe a not tolerate the oral intake. So we should escalate that to the consultant, and we should start the TPN on time. Laboratory trends indicating sepsis and marrow suppression. With the help of laboratory investigations, we should identify the early signs of the anemia for the and WBC for the sepsis control, and for the platelet for the bleeding control. These are the missed opportunities. The first and foremost, the earlier recognition of relapse at peripheral level may have reduced the disease burden before transplant. If the MRD diagnose, if the MRD test done earlier, then it should be burden should be less in for the transplant. And other missed opportunities highlights the importance of early referral and vigilant follow-up. So after ALL remission, there is some gap for the follow-up itself. As per the Dharini's case, the best practices are the adherence to febrile neutropenia protocols. In that case, they had all the neutropenic protocols are followed, aseptic techniques followed, very good line care management was given. Early escalation of the cytokinase release syndrome was escalate on time. After the chemotherapy, CRS found and it was escalate on time. So on the tezolizumab was started, antimicrobial was started. So patient had prevent from the septic shock, and evidence-based infection prevention followed, and that family center communication was done also. What well went? First is the evidence-based intervention done, timely administration of tocilizumab for CRS, appropriate antimicrobial and antifungal coverage was given, GCSF support until engraftment, and effective mucositis and supportive care management was done. Effective teamwork shown, strong nurse physician collaboration, infection control practices followed, coordination with multidisciplinary care, and nurses acted as central link between patient, family, and the clinical team. What are the key takeaways? First, early identification of high risk status is crucial. Timely escalation prevent infection, bleeding, clinical deterioration. Structured communication improves clarity and decision making. Multidisciplinary coordination is essential in complex hemato-oncology cases, and nursing leadership ensures safety practices and protocols, adherence, effective escalation, supports safe preparation for allogenic stem cell transplant. My humble request to student for the next discussion.
Yes, ma'am. Good evening, ma'am.
Good
Good
evening, dear.
evening.
Thank you, Swapna ma'am and Sarmista ma'am, for giving me this wonderful opportunity to speak. And thank you, Poonam ma'am and Dharini ma'am, for a beautiful explanation of this complicated case. And from my point of view, this case of acute lymphoblastic leukemia taught me that even the smallest changes can show the biggest warning in the patient. And as ma'am taught us, that early recognition of subtle changes and yes, prompt acceleration can directly impact the patient condition. So, as a nurse, we should not miss that. And this case also taught me that as a nurse, my work is not only the routine care of the patient, but yes, my work is also patient advocacy, patient safety, and clinical judgment of the patient. So, regarding this case, I would like to present 2 or 3 questions and answer them. I hope the screen is visible.
Yes, dear.
Now, my first question is, what did this case teach me about recognizing early signs of patient deterioration? So, this case made me realize that as a nurse, the observation of fever, diarrhea, and hypotension is not small in post transplant patient. It can be life saving condition for the patient. And early identification of these red flag, as Poonam ma'am told us, can be life saving for the patient. Now, moving to second question, that is how has this case influenced my understanding of timely acceleration and the nurse role in patient safety? So, in each case, there is not only the diagnosis, but there is a life depending on how quickly we notice the small changes. And as a nurse, we are often the first one to notice that small changes. And as Poonam ma'am told, that effective communication and quick communication with concerning team members can be the quite role in patient safety. Now, moving in third question, that is what action should a student nurse take when subtle changes indicate the impending deterioration? So, when subtle changes indicate impending deterioration, as a student nurse, first I would assess the patient, then assess the changes occurred in the patient from previous condition, then quickly go with the concerning team members for clear communication. And along with that, I would start the immediate actions like O2 therapy, IV access, and yes, necessary investigations which are crucial for the patient. After that, continuous monitoring, even when the patient is stable. And yes, standardized infection control protocols are also very necessary because if we not control the infection control, patient may have infection and his condition might worse, as in this case. So, as a nurse, our duty is to prevent the further deterioration in the patient condition. So, from all this, I would like to tell that my takeaway is in the critical care unit, it is not the loud alarm, but the quiet changes like the vigilance, nurses' timely action, and nurses' teamwork can definitely help patient in recovering the conditions. So, thank you all of this from my side.
It was a nice presentation from the all three. It is really appreciate you have presented very well. Now, now it's time to open poll. Is there any question from this all expert speaker?
Yes, ma'am. I have one question. Is there
Yes,
any
please.
specific guideline about vaccination of BMT staff?
Yes, please. One hand is raised.
Ma'am, the question was asked from Nidhi Patel. Is there's any specific guideline for BMT staff?
Yes, there is a specific guideline for the BMT staff. Am I audible?
Yes, please.
That in BMT, the normal critical care management should be learned, but the foremost is the to teach about the any interruption is there.
Ma'am, you're audible, ma'am.
Okay. So in bone marrow transplant, like ICU, in ICU we have to teach about the line care management, intubation, ventilator care, uh, all these things are there. But for the bone marrow transplant patient, we have to learn for the CVAD, like Hickman is there. Dialysis should be taught to them, and all foremost the environmental control. That what is the HIPAA filter is there, how much microns are zero point 0.3 microns are allowed, which is the critical signs for the bone marrow transplant, which are the reports is necessary like CRS, then MRD, then chimerism is there, and what is the antibiotic or antifungal or antibacterial is needed for that patient, and what are the indication for that, and what are the complications for that. So this is the specific training should be given at the time of induction for the BMT staff, and for that we and chemotherapy administration. So which are the chemotherapy agents, and what are the doses, how can we dilute that, what are the safety during the chemotherapy. So all this training should be done by the hospital staff, and there should be a preceptor or mentorship should be there. In that the senior registered nurse is involved, and for the specialized training the hemato-oncologist should involve in their training to understand the critical stage of the patient. And in bone marrow transplant unit, what happened? The so volume of, matlab, more of the blood transfusion is administered. So we have to give the education on the blood product, its transfusion, and its complications, the blood transfusion reaction, early detection of the blood transfusion reaction, and what are the best practices followed for that. So many new things we have to learn for specialized BMT nurse is like that.
Namaste, ma'am. Namaste, ma'am.
Namaste.
I have a question, ma'am. As it was mentioned in PPT, BMT induction is mandatory, and there are any mandatory topics that must be included? Are there any mandatory topics that must be included?
Yes, as I mentioned with his question that yes, mandatory topic for the CVAD care and management, then blood transfusion reaction and blood transfusion product monitoring, then the early stages or the early diagnosis or early signs of the bone marrow transplant, post transplant patient chemotherapy administration safety, then the infection control protocols for the BMT patients, and the patients and staff safety or the prevention for the injury is taught is a mandatory for the bone marrow transplant patient. What are the stem cell transplant complications and its management, graft versus horse disease, is also included for that training.
Thank you, ma'am.
Good afternoon, ma'am. It's Manoj here. My question is that what are the strategies that nurses can use to support the antibiotic stewardship program in such critical cases?
Very good question, because as in the bone marrow transplant, patients have a high WBC count. So, patient immunity is very low. He or she is susceptible for going for septicemia or the septic shock. So, antibiotic stewardship is a very critical for that patient. We should give antibiotic in a golden hour within 30 minutes of the symptoms. If patient had a low if pancytopenia, or patient is in neutropenic phase, and patient had a sign one episode of fever, then antimicrobial or the antifungal or the antibacterial should be given within 30 minutes of time. So, in bone marrow transplant, what should be a protocol that there is no need of any culture report. It should be started on empirical basis. After that, before, and culture should be sent at simultaneous level, either or the blood culture or the line culture or the urine culture we can send, but simultaneously the antibiotic sort, first sort, should be given on time, so we can prevent septic shock to the patient and mortality will decrease in that case.
Thank you so much, ma'am, for the wonderful clarification on my questions.
Namaste, ma'am. Myself Khushali. I have one question. What are the critical reports in such cases which request to be communicated following at most standard?
Please repeat.
What are the what are the critical reports in such cases which request to be communicated following at most standards?
As a nurse, we should escalate the as I mentioned, the CBC report. In that, hemoglobin, if it is decreased by 6 or 7, the WBC count is, if it is increased by the 8,000, and the platelet count if it is decreased by the 25,000. Second one is the electrolyte, in that the potassium level is what. Third one is the creatinine report. Fourth one is the that culture report. So it should be proper investigation should be there. We have to take follow from the lab staff for the proper reporting on time, and if any deviation is there, if any critical value is there, it should be escalated to the hemato-oncologist, as well as the liver function test. We should look after the SGPT level, bilirubin level, because in there is a multiple drugs is going on. Multiple high dose chemotherapy was administered. Multiple blood products were given. Multiple antibiotic, antifungal, antibacterial was given. Immunosuppression drugs was given. So there may be a chances for the multi-organ failure is there. So we should look after the CBC level, creatinine level, potassium level, calcium level, SGPT, and all these things on a timely basis, on a very vigilant way.
Thank you, ma'am.
Is there any question?
Not question, then we'll summarize. Okay. So I think it's a wonderful session, and I have seen the response from the audience is what the question also very wonderful, and I am sure everybody has cleared that doubt. Before closing the session, I heartily thankful to Ajita Madam, Elizabeth Madam, and Thangam Madam to giving this opportunity to Gujarat team. I special thanks to Sapna to coordinate this all speaker and yes, me too, as per the schedule. I thanks to Poonam, Dharini, and the student. You have presented your case study very nicely. Once again, thank you everyone, and we see you soon again for the next opportunity to present such a very good case study.
Thank you,
Sapna,
ma'am.
any question or comment from your side?
Ma'am, thank you. I really want to thank Elizabeth ma'am and Tangam ma'am for the opportunity they have given us. This is the first time we are doing, and the next time when we do it will be more better than this. We have done our best, but
Yeah,
it will be more better.
yeah, that's
Thank
great.
Poonam
you, ma'am.
ma'am, thank you, Dhari.
Thank you, everyone. Thank you.
It was a
Thank you,
wonderful
ma'am.
presentation.
Swapna, we should take a group photo.
Yes,
Yes,
ma'am.
please. All right.
Ma'am, just 1 minute. I need to arrange it before taking a group photo.
My humble request, please on your camera for the group photo.
Just 1 minute. Let me arrange it. When I say go, that time everybody has to smile, okay? Okay, so 1, 2, 3, smile. One more click. 1, 2, 3, smile. Thank you so much.
Thank you. Thank you, everyone. Thank you very much.
Thank you, ma'am.
Thank you, ma'am.
Thank you.